Good afternoon. My name is Linda Protopappas. I'm the Executive Vice President of Sales for HealthRecon Connect. I'd like to welcome you to our webinar this afternoon. To walk us through this webinar, I have the honor to introduce our Director of Laboratory Services Support at HealthRecon, Mr. William Baus. William has over 15 years experience in healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management, building offshore, onshore, and hybrid teams to satisfy the needs of his client. William has worked inside laboratories as the Internal Revenue Director with preview over every step of the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenue for laboratories, whether that is through adaptation of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs. A few reminders to all of our attendees. If you would like to ask a question, please do so at any time during the webinar via the chat box or raising your hand, upon which I will definitely call on you and we can ask those questions for William. Following the conclusion of our webinar, please take a few minutes of your time to fill out the short survey. Let us know what you liked about this webinar, how we can improve, and what other topics you'd be interested in for future webinars. Also, within the next few days, we will be sending out the slide deck for this webinar, as well as the video portion of it. And with that, William, the show is yours.
Thank you, Linda. And I'm so happy everybody took the time to join us today. We will also record this and upload this if you need to peel off after maybe one of the topics of your current interest is been satisfied. But there's a lot of good information in here for us. So let's get started. So notice we're not providing you legal advice. We're not providing you clinical advice. If you take any information from this webinar and use it, we don't guarantee any outcomes, whether explicitly stated or implied. And we accept no liability if you do something and you don't get paid or you get a recoupment. So take this information and use it as you will. But if you work with us, we definitely make sure that we put this together for you correctly. Let's see here. Okay, so I think there might be a good pause after we talk about these NCCI edits to look for questions and see, well, if you have any questions, we'll start addressing those right there. Then I'm going to jump into the basics that are pretty much the same across all MACs, but you'll see pretty soon we've got 26 different versions of what's going on between the different MACs at the moment, but they're actually normalizing pretty much against what the Palmetto LCD is, which just dropped today. And we'll get into all of that. And then I'm going to look at compliant confirmation maximization, which don't get too excited. It really kind of means mostly it's GO480 or GO481 and why that is and what you can do to maybe optimize your system so that your orders match what you're going to bill, which is something that's rather important to take a look at because technically it can constitute a false claim. If you end up billing a lower code simply because that's what you'll get paid for when that's different than what was ordered. And so we need to talk about that. And then I go into a comparative analysis between the various MACs, which will be predominantly useful for two reasons. One, to show you the progression of where your current MAC is and where it's going to go to, so you can be ready for that. And then also, if you did have laboratories in multiple MACs, it might give you an understanding of why you're getting paid differently in different MACs for your toxicology. And then some requisition concerns that I've noticed throughout my travels through labs, that questions pop up and what should I do about signatures and diagnostic codes. So with that being said, let's dive right in. Okay, so this is the thing that's kind of messing everybody up right now. NCCI is the National Correct Coding Initiative. It is a CMS program, but almost all payers consume NCCI edits for P2P, which is peer-to-peer edits, which is predominantly what we're concerned with in this particular NCCI edit that has gone awry. And then, of course, MUEs, which are medically unlikely edits, which you're probably also familiar with, in that if you use a particular code multiple times on one date of service, the limit for how many times that's expected to happen, and for which you will receive a denial for automatically by any system that consumes an NCCI edit and uses those to adjudicate claims. You don't get paid after a certain number of units. That's what an MUE is. AOCs don't really happen for us in labs, but they're add-on codes. But those three things are what NCCI is predominantly as a program concerned with. It is, again, a CMS program, but again, even commercial payers use it. And in fact, there's something now that a lot of payers are using called smart edits, which we'll talk a little bit more about here in a second, would use those as well to kind of create those rejections, which is kind of interesting too. If you've had denials that tell you things like, oh, you can't appeal it, it may sound like what they're saying is, I've denied you and I'm not going to even let you appeal it. That's not what's happened. You've actually had a rejection. And a brief moment, if I may, to explain that, well, when a claim goes to a payer, if they don't accept the claim, you don't have a claim, and it never got on file. And so if it never got on file, then you can't appeal it. That's all they're trying to tell you. But it usually scares people when they see that. They're like, oh, I got denied and I can't do anything about it. No, you didn't get denied. You just didn't get accepted. And until you fix whatever that smart edit is talking to you about, your claim will not be accepted into the adjudication process. Now, it is also at that time that you could then have an NCCI edit show up later, because they might use NCCI edits in their adjudication process and not just in their smart edit process to reject you. And not everybody uses smart edits either. But United does, and a number of Medicares do, and another of other commercial payers do as well. So here's what happened, right? Medicare, in their infinite wisdom, or the NCCI in their infinite wisdom, decided on July 1st that they were going to implement an NCCI edit, a peer-to-peer edit, a CPT code to CPT code edit that says, well, if I see this CPT code and another CPT code, well, then I either may or may not pay you for that other CPT code, depending on whether or not I allow you to use a modifier to bypass that edit. And so what we've got here, whereas I just used GO480, which is, if you're familiar with urine drug testing or toxicology or controlled substance abuse monitoring, is your 1 to 7 drug classes for your definitive confirmation test. So what this edit is telling you is, oh, a payer that's using NCCI, or a smart edit that's using NCCI, and pretty much all of them do, looks at and sees that you built a GO480 as a column 2 code, it's going to go and look for any of these other codes over here on the claim. And if it sees them, it's going to deny you if you don't have a modifier. And in this instance, see how they're all set as 0? That means the edit is set to, there is no possibility of an override. So regardless of a modifier or not, we're going to deny you. Well, that makes a lot of sense with another confirmation code. And all these codes here with use, these are all PLA codes, which are all basically proprietary laboratory analysis codes that some lab has taken the time, takes about 2 years to do it, to create their own CPT code in relationship to some kind of drug confirmation. So it makes a lot of sense that they're not going to let you bill 2 confirmation codes, because the way the confirmation codes work is it's either 1 to 7, 8 to 14, 15 to 21, or 22 or more. So there's really no reason why you would try to put a 14, drug class 1 with a 22 drug class 1 together, because it's 22 or more. So there should be never any possibility that this code and that code would be billed on the same claim form. And that's exactly why these peer-to-peer edits are made. They're meant to catch, well, basically a billing mistake, or somebody that has a lack of understanding about what the code is designed to do or represent. But what they erroneously did, and Medicare is clear that they screwed up, right? And we're going to take a look at that in a second. What they should have done is set the 80305 to 80307 to ones, which would allow you to put a modifier on it and override the edit and allow you to be paid for 2 codes. So this NCCI edit is here to stay, and it will never go away as far as I know. But that's okay. You will have this updated in October to this being a 1. And when that's a 1 and they see those 2 together and you have your appropriate modifier on your appropriate G code, then you would be paid. So let's take a look at that. So this is what Medicare did, and they buried it. And so it kind of sprung up on a lot of people because there wasn't a lot of communication about it up front, right? They kind of buried it in here under the section for, NCCI, and they made a little announcement. And they do this every quarter, right? They'll update what these edits are doing because new codes come up or new rules come up, and they're gonna do this every month, or not every month, every quarter. And so you might also see variation in when a payer will start giving you these denials, because, well, they have to take this NCCI edit and load it into their smart edits or load it into their adjudication system. And they might not all do it exactly on July 1st. And these are done by date of service, not by the date that you submit it. So the NCCI edit that's going to be applied to your claim will be looking at a particular date of service for the claim to look at what edits it should be applying, which probably has something to do with why Medicare is like, but yeah, it's going to take us till October to fix this problem, because it's not just one file and everybody's using the one file and everybody knows how to use it and when to use it. But yeah, clearly it's a simple matter of changing a 0 to a 1. And of course, any payer that is using this file could change that 0 to 1 on their own, and some have done so. So you're going to be paid if you've put the modifier on the appropriate code. But basically, all of this communication here is them saying, yeah, we know we did it, but we'll implement that change next quarter on October. And Medicare is basically like, yeah, well, so, what you could do is just not submit any claims until next quarter, which I find unacceptable. Or you could go ahead and bill it with the modifier. And of course, you're going to get a rejection on the G code because the edit isn't set to allow it to be paid. But then, oh, don't worry, we'll get around to coming back to you and paying you whenever, which I don't think that's a very good option either, right? So what I think would make the most sense, and you're going to need to make your own choices on this, but if you wanted more of your money, then if you understand now what an edit is, it's when 2 codes go together. Well, then your option is to bill 1 code. Then the choice becomes, well, which of those codes do you want to bill? So you got your 3 choices, right? Bill both codes with the appropriate modifier on the G code and get paid for your screen. Bill 1 code and then not experience an edit, and then you'll be paid for the 1 code that you bill. Or do nothing and wait until October. Maybe they fix it on October 1st or 15th or the 3rd or whenever, I don't know. which is kind of interesting because remember, I told you that edits work by date of service, but they can't work by date of service until they're actually changed or implemented. So whenever they get around to it in October, it's going to go all the way back to anything that you had a denial on by date of service of July 1st. So if it were me and I wanted to make 70% of my money instead of 30% of my money, I'd probably bill my GO480 or GO481, or if appropriate, perhaps your GO482 or GO483, which then it would be even more than 70% of your money that you would be getting up front. We'll get into talking about proper G-coding, I guess, is what we'll call that. Other things to consider about this within the issues that you're going to have are going to be, well, am I getting denied or a smart edit reject? So payers that don't use smart edits are going to accept your claim up front. And then at some point in their adjudication process, they're going to start applying NCCI edits in their adjudication. Adjudication might sound like a weird word. Just to give you a little brief description on what that's all about. The adjudication process is what does a payer evaluate on a claim to decide if they're going to pay you or not. And smart edit rejects are looking for things up front before they even get into the adjudication process. And depending on what smart edits have been implemented or what that smart edit has put into it to analyze against things, then you're going to get different kind of smart edit rejects from different payers. But if somebody was using smart edit and it had consumed NCCI edits, it's then going to apply this erroneous edit, which they could also change themselves to that 0 to a 1 to allow the override, but they're probably not going to do that. But there's kind of a benefit to a smart edit reject, and that would be, well, at least you didn't get paid for your screen, so you now have the option to go back and send out your claim with the G-code on it to get your confirmation paid up front. And the exact experience, you might say, well, don't you need to do a screen first before you do a confirmation? Yeah, that's right, but we're talking about billing, and they're the ones who've screwed up an edit. And I don't think waiting for my money is really something that anybody should mess with me about. So I should get as much of my money as I can up front. Now, I'm not even getting into whether or not you should or shouldn't be billing a confirmation. This, of course, presupposes that you got a valid order for a confirmation and you've got the right G-code and the order matches what you've billed, right? All of that. But assuming all of that's there, then yeah, you can go ahead and bill that. It's very common for laboratories to work with referring physicians that run the screen themselves, and thereby the lab is only billing a confirmation anyway. So it's very common to bill just the G-code anyways. So yeah, smart edit's kind of your friend in this scenario, because now you didn't just get paid for your screening code, right? You'll have a chance to just bill your confirmation code if you so chose to do that. Well, if you already got paid for your screen, my personal opinion on that would be, take that one on the nose. But now that you know that a particular payer is doing this to you, I would just start billing my confirmations until I was able to confirm that they had updated their edit. And when the edit is updated, and if I've already got a G-code with my 59 modifier on there, then I'm going to bill my 80307 on a corrected, updated claim, and I'll get the other 30% or less of my money. And then there is kind of a problem where you're kind of not in a good position if you are one of those labs where your providers are billing for the screens, because yeah, they're going to bill their screen. And if they get their screen in before you get your confirmation, and then they're going to get paid for the screen, and then you're going to have to wait for the edit to kind of get updated. All right, so let's pause there for a moment and see if we've got particular questions about that.
We do have one question in the Q&A, William.
Oh, fantastic. Let's see what that is. Slide 5. We're on slide 5. Okay. 3 choices. Bill one code and thus no edit. If you build just one code and not the order, then isn't that unbundling to avoid the edit? Unbundling. Well, there are two separate services, so you're not unbundling, would be my answer. But again, completely what you would want to look at, talk to your own lawyers about it, feel how you're looking at it. But unbundling is when you have a bundled code, and we don't have a bundled code scenario here. Your screen is a separate service from your confirmation. Which is in fact why that 59 modifier exists, right? The 50, I'm not going to get into talking about 59 XU or XS. That's another thing you're going to want to talk about internally, how you do it. My personal preference on that is every LCD I read about laboratory, they talk about 59. The XU and XSs seem to be more appropriate when you're talking about surgeries and those sort of things. But I've definitely had lawyers take different opinions and viewpoints on that. But I can also point at pretty much every LCD you're going to look at for laboratory services is going to tell you to use a 59. All right. Any other questions? I don't see any. Okay. All right. Let's move on. Let's get started. So what I'm going to do now is run through basics. These are the elements that I've now recognized after looking at the current and proposed and retired LCDs. So there's about 50 documents across these MACs, whether they're like, for example, Palmetto is basically the model. It's been well documented in the conversations that the CAC meetings have been having, that they want to standardize LCDs across all of the MACs. And the first one they're doing it with is with toxicology. And we're going to have basically it, as I'll kind of give you the flow of what you can see how the changes are, to kind of look through all of that and see that it really is going to that kind of a model. So there are some additional questions. Let me read those.
Yes, on the Q&A, sir.
All right. Over there. Doesn't 59 trigger medical records requests? Well, yeah, many of the LCDs will talk about that. And in particular respect to this, we are talking about an NCCI edit, a peer-to-peer edit. And the override for that is a 59. I don't know the XU or XS, right? But either one of those are going to trigger it, because you're saying it's a separate and distinct procedure. And so you're kind of raising a hand at something that Medicare is usually saying they don't expect that, which I think is kind of stupid in this scenario, because they're telling you that you need to do a screen. I mean, there's lots of LCDs that say that, you know, they want you to have done a screen, because they're still thinking this is like 25 years ago, where the idea was you would do a screen, deliver that result to the doctor, they would look at the result, and then they would order a confirmation. In fact, that's what Aetna still expects you to be doing if you read their LCD, and I'm actually going to show you guys that later today. But there are plenty of reasons to go direct to confirmation and not use a screen. And you'll see that as well. So yes, 59 in general will do that, particularly when we're talking about molecular pathology. You've got some LCDs that address that predominantly in the Novitas and First Coast and NGS regions, because you don't really have to worry about molecular pathology that way in the MolDX regions because of C codes and technical assessments, which you probably never got, so you're not billing it anyways. But where you don't have people doing those LCDs and Z codes, you're going to have it's a way to kind of signal to the payer that you're doing something that they think isn't standard. It shouldn't always go together. And that's really what Medicare is telegraphing by this implementation of the 59 modifier is you don't always need to be doing a confirmation. And so that's what's happening here. So the next question is, if the ordering provider bills the screen, does the lab bill the confirmation with modifier 59 eventually, since it's the same date of service but different provider? Yes, you will. Depending on how different people have implemented their systems and how Smart Edit's going to look at that and how it's designed for NCCI, it is an absolute date of service edit. So they don't care where it's coming from. They're looking at the patient, they're looking at data service, and they're going, oh, those two things happen together. Now, the thing that you might have happen to game that system might be, well, what if you build your confirmation first and then they bill their 87, I can't even say the code, 87803 or 87880, the screen code. I'm having a brain malfunction right now, 87803, for the screening code. If you build your confirmation and there's no screen code, then it's not going to see that when it processes your claim and pays it. I would still bill it with the 59 modifier so that eventually when somebody did do the 80307, that you don't get somebody go on a look back and say, oh, you didn't have the modifier, and then recoup your money, and then you have to rebill it with the 59 modifier. Hey, Soledad, good to see you. We have been billing GO 480, but still get denied with required medical records. Please advise. Well, just call me after this and let's look at the denial. I can tell you this, we have been billing and just the G code, and I have confirmed payment from the Medicares that we're billing. I don't know if it's been a Noridian yet, where I assume that that's where your problem is. But yeah, just give me a call. We'll go over it. I mean, you might just be getting a regular denial. That was something that was confusing some of the teams that we had where, yeah, you're getting denied for a GO 480 because they've got a problem with something else, right? Because they've asked you for medical records. Although it's interesting that we're getting a problem with a GO 480 on a request for medical records, and I have seen that recently. That's not really the NCCI edit issue. At least if they're asking you for medical records, it's not this NCCI issue, right? That's something else. And yeah, let's talk about it when you get a chance. I'll be available later today. So do we have one more? No, that's just one open one. That's
Right.
Yeah.
We're good for now.
Okay. All right. Okay. So basics and how we doing on time? Uh-oh. I'm going to have to sprint to get to the goodies. Okay. So everything that I'm going to kind of sprint through here, this is the core of it. Whether I'm talking Palmetto or Noridian or Novitas, this information is pretty much the core of it, and it's extracted predominantly from the Palmetto LCD, which was just today moved from proposed into active on 8/15. And as you'll see, when I've kind of got a spreadsheet kind of showing you the evolution of this, you'll kind of see they're all going to be kind of updating to this point. And I'll point out some very specific elements that can be problematic. Okay, so we all know what presumptive is. It's qualitative. Definitive is quantitative confirmation. Presumptive is qualitative screen. Two kinds. You got immunoassay. That's 80305 to 80307. So 80306 and 7 and 5, right? That's what these guys are. And then, I think there's a G code for POC cups. They will only pay for one screen on any one data service. In multiple LCDs, Sometimes they don't bother mentioning it. And just because they don't bother mentioning something in one LCD doesn't mean that that isn't something you're already supposed to know. I think just certain MACs kind of highlight something because people keep doing it to them, right? Like 2 or 3 of the MACs keep talking about the individual drug class codes, like don't bill those, or that those are non-covered codes. Most of the MACs don't even bother telling you that because, well, it's been over a decade since they've been doing it. So I guess some people show up on the scene and think, oh, hey, man, I figured something out. Although it's also interesting, too, you've got some Medicaids that actually want you to not only do the G code, but then they want you to put in the actual drug class, individual drug class code, so that when you say you did, 1 to 7 drug classes, you need to have at least one individual drug class code to tell them which drug class you were confirming, which actually makes a lot of sense to me. I mean, if you kind of follow the thought process on there, that makes really good sense. Tell me which thing it was you were actually confirming, and they can see that on a claim, which would reduce your requirement on medical requests. And I would welcome that to be the case. It would be a little bit more complicated from a billing perspective, but it would be less complicated from a documentation perspective because now they would know what the heck it was I was confirming. All right, let's move on. We got to get going. Okay, standing orders, yeah, they're okay. Probably is going to have to do with nursing homes. You can do it with regular physicians as well, but you got to be very careful. Soledad knows. Standing orders are specific to the patient, individualized to the patient, and should be updated regularly. Although at the moment, I'm not finding anything specific about it, but if when they talk about it in the OIG compliance plan, they're actually referencing renal testing and that you should do it every year. I think if you are going to employ standing orders, you should also be doing an expanded look at your OIG compliance plan and your provider acknowledgement and your onboarding documentation, and that you're going to update that at least once a year, I would suggest, if not more. Again, that's kind of now moved out of the realm of legal, and now you're out of the realm of billing into legal. There really aren't, well, it's not even addressed in any of your LCDs for Medicare, for example. Maybe in some of the commercial payers, they might mention it, but usually they don't. They're very terse to their benefit to be a little ambiguous in how they tell you what you can do or can't do. But certainly they're not forever, right? And you want to get confirmations, and you want confirmations in writing that it's been updated, and you should get a copy of it, right? Blanket orders, alternatively, are not specific to the patient and are the same for everyone. And so somebody just saying, hey, anytime I, order a UDS, this is what I mean, and I mean that for all of my patients, bad idea. Now, reflex testing is your savior, right? Here's the thing that I think everybody should be doing. If you want to match what you're resulting and what they're ordering to what you're billing, reflex is your buddy, and we're going to talk about that in a little bit more. But you can't reflex off of a point of care test, a POCT. But you could reflex off of your own immunoassay analyzer. Okay, so here's some things that they repeat again and again throughout all the LCDs. They might kind of format it a little differently. They might put it in a different order, but they're all saying this, right? Presumptive UDT point of care testing is questionable. Medicare knows this. They know that it's not really a good test. You should encourage or educate your providers that really they shouldn't be using them. It's widely known that they're heavily inaccurate, and this is exacerbated by storage and how old they are and a whole bunch of other things. But they really should only be used when they need to know a result immediately. And then even then, they can't really trust that result if it's negative, right? Presumptive UDT by instrument and chemistry analyzers are more accurate. Okay, yep, thanks for letting us know, Medicare. And then limitations. This is where you need to perk your ears up, because these are reasons for going to confirmation. This is why you confirm something, right? Okay, screens for drug classes may not distinguish between drugs of the same drug class for a positive result. Sometimes people use the word speciation. It sounds like a made-up word, but I've heard people use it for 10 years that are like pain management doctors and stuff like that. So if you're looking for, I want to know if it's a particular opiate that I've been prescribing or some other kind of opiate on your screen. It may not delineate what that is. So that's a reason why you need to confirm it, and should be documented that way. Can produce erroneous results due to cross-reactivity with other compounds. So you really need to be working with the people that set up your screen to understand what your screen is doing for different medications. And I think in part of your reflex, you should be communicating that to your doctors that, hey, we're going to reflex on medications that might produce erroneous results due to cross-reactivity of our screen related to these meds. That should be in your provider acknowledgement that they sign off on. So when they sign up for a reflex test, they understand what they're ordering. But that'll give you another reason to count another drug class in your confirmation. And we're trying to get to 8, right? I mean, that's pretty much about as many as you're going to get. That's why the GO483s and GO482s aren't there. That's why they tried to throw them out. The original versions of these proposed LCDs went down to 14 drug classes, which were completely off the books. I mean, like, they had no relevance to science. And some of the current LCDs that will be changing to their proposed LCDs, where those tables disappear, they have drug classes called illicits. There is no drug class called illicits. There's cocaine, right? There's amphetamines, but there's no illicit drug class, right? So that's really more of a menu kind of thing. And I think the reason they're moving away from that is because they do want to be taking a look at your order and your result and what you're billing are matching. That's going to start coming up a lot more. And they couldn't have got you for that if they can't even get it straight what a drug class is. So that's why that stuff's going to disappear, I think. It may not detect all drugs in a drug class. So again, if there's a med that is not detected by your screen in the drug class that it's working in, then that's a reason that you need to confirm that. And that should be written into your provider acknowledgement. Cutoff may be too high to detect a drug or drug class. Again, provider acknowledgement could be a reason for you to move to confirmation. And again, I don't know what your screen is set up as. I don't know what drugs you're testing for. So it's inappropriate for me to say that that's surely a way to do that. You have to work with your your med techs, your medical director, and look at the drug classes, the drug list that you're confirming and what you're screening to see where these things fit in, so that you can instruct somebody. When you say a reflex, you're going to reflex on all of this stuff to make sure the doctor gets his order, gets the results they need to manage the treatment of the patient. And that's another thing. Some people are telling me now they don't even get the med list from the patient. I wouldn't be billing confirmations if you don't get a med list from your patient. You got no reason to confirm anything if you don't know what they need to confirm, right? So that's a no-no, right? These limitations may mean that presumptive testing is insufficient for certain clinical needs. Bingo, right? Okay. Presumptive UDT cannot identify specific drugs within many drug classes, particularly, and Medicare's aware of this. They're telling you, they keep repeating this. They're like, yeah, we know that for amphetamines and barbiturates and tricyclics and opiates and opioids, we know that your screen can't do it. Confirmation. Presumptive UDT for certain drugs yield false negatives due to low cross-reactivity or non-reactivity. Like, they're telling you, they know it. Some drugs can't be detected. You might not have a commercially available. They don't really say this anymore. They used to say it that way. Now they're kind of saying it this way. But if the doctor is prescribing a med for a patient and needs to know about that med, then yeah, that goes straight to confirmation because they need to know about that med. And now, what does it mean to be commercially available? And is it okay for you to do that because you didn't set it up on your screen? I'm not getting into any of that with you. I wouldn't try to game the system, but if they are not commercially available or not something that you normally screen in your area, and it's something new that hasn't happened for you yet, like maybe when bath salts popped up, or there's some new drugs I think that are going around, and you need to be able to do that, you can't get a screen for it, well, that's the reason to go to confirmation. This is kind of really just honing in. They keep saying the same thing in slightly different ways, but again, it's the same things we were just talking about, right? You need to identify specific drug. Well, that's going to be related to the med. Identify specific substance that is not adequately detected by the screen. If they're prescribing a med and they need to know that, then yes, that's an important thing. That's going to be coming from your med list. Identify a specific substance or metabolite that is not detected by, such as fentanyl. Again, if you need to know that, then that's okay for you to do that. If you don't need to know that, and we're not worried about a substance use disorder abusing that, because that's not what they're after cocaine and amphetamines, then it's probably not appropriate to start trying to do that. But that's what the doctor should be telling you is, I want you looking for these meds. They give you a med list of either being prescribed or in substance use disorder. These are the meds I'm looking for on this patient, right? And I need to know that because this is their drug of choice. Identify drugs when a definitive concentration of drug is needed for management. Yeah. And then again, they kind of repeat the same thing: differential assessment, identify non-prescribed medication or illicit use for ongoing safe prescribing of controlled substances, rule out as an error as a cause of the presumptive UDT result. That one really only makes sense if you've already sent a result, which this would never happen the way most people do it, because everybody's ordering a screen and confirmation. But if they had only ordered a screen and then they were pretty sure that that was wrong, and then they wanted to confirm it, that would kind of make sense, but it doesn't really make sense the way that we're geared up, or most labs appear to be geared up. Identify a negative or confirm a positive presumptive UDT result that is inconsistent with the patient's self-report. Again, very difficult to incorporate that into a concept of them ordering the screen and the confirmation together, and you reading a report to figure that out. It's going to be real hard to implement, but there are ways to do that. It's medically necessary when ordered for a particular patient based upon historical use, clinical findings, and community trends. That's repeated multiple times. Same profile is not reasonable and necessary for every patient and physician's practice. Yeah, they're saying not a blanket order. And I'll get to that question in just a second. And then definitive UDT orders should be individualized based on clinical history and risk assessment and must be documented in the medical record. Yeah, if we could do that, that would be great. Yes, we need to educate our doctors. We need to tell them we need this documentation if they want us to do this testing. And I could say that all day long, and then we're still going to take the orders anyways because we're a lab. This is a question. What should the criteria be to append definitive code if there is not any positive drug class? Okay, so let's kind of break that down. That could be interpreted in multiple different ways. I just went over some of those elements of what that would be. If there's a medication for the patient that you couldn't have screened, thus it couldn't be positive or negative, and the doctor needs to know a result on it, that's a good reason for it. And there are 4 or 5 other reasons I just said that would qualify for an answer for that. Can we use a G code on the basis of inconsistent? Can we use a G code on the basis of inconsistent screening results? Not sure exactly what you're saying about what screening results there are inconsistent, but yeah, that's exactly one of the things that we just said, right? Inconsistent. When you've got inconsistent with a patient's self-report, so, or inconsistent with anything, right? Like I'm prescribing a med and it's negative on the screen where it certainly should have popped positive for the drug class at the screening level, and it's negative. Well, then, yeah, I can confirm if they're really not on it, right? So if it's inconsistent from the expected result, then yeah, that's one of the main reasons to do that. Yep. Okay, so more basics. You got 3 groups. You got group A, B, and C. Group A is probably not applicable. Anybody got any questions about this one? Go ahead and ask. But in most independent labs and physician-owned labs, you're not going to see this. And frankly speaking, I don't even understand how that's going to happen. Even if you were in a hospital, I don't know how an LCMS is going to get done finding this information in any time to do what is designed here to do. They're trying to figure out what you've got in your system so they can find an antagonist to kind of help you, right? But I guess if you're in a coma, maybe there's enough time. But if you're like dying, and you've got severe cardiovascular instability, I don't know how you're going to get that done fast enough to make any difference. But that's when you bill a G0483. Everybody's like, well, why do they have a G0483? And they almost tried to take them away, guys, because everybody's like, well, why do they have the code if I'm not supposed to bill it? Well, this is why, because that's when you need to know everything and you need to know it right now. And yeah, you wouldn't need to do a screen. You just go straight to confirmation. Okay. Group B, substance use disorder. Okay, so these are people that are, in drug rehab and have had a problem with a drug addiction. And they give you a bunch of specifics about this. This is very similar across all the MACs, even in the old versus the new. This is not the parts that are changing. These have pretty much remained solid for the last 20 years. And they're pretty much this way for commercial payers too. You're going to have problems with commercial payers on substance use disorder because they're already paying $700 a night for people to be in that rehab. And so a lot of them are starting to say, yeah, I'm not paying for this under my mental health benefits anymore. But there are different carve outs for ways of looking to understand that. If you end up having those problems, come on over to us, we'll help you out. I would read this again on your own. It's just telling you, what you want to base your profiles on. It's kind of hard to relate this to a code selection thing, but this is why they should be ordering it. You should understand that if you have a large population of substance use disorder, people ordering with you, and then what the testing profile is. These words sound like they don't mean much, but they do mean a lot to Medicare, right? This is what they're asking you for when they're asking you for medical documentation. What explicitly and specifically do you need in them? You probably want to take another hour talking to people about that. But patient history, the stage and treatment and recovery, and that kind of ties into frequency. And we're going to talk about that in a second. The different things, these all need to be documented for that to get your medical necessity. So for Group B, substance use disorder frequency, they're all moving towards this. This really isn't different than what it's been, just the way that they say it. It's instead of how many days of treatment, it's days of abstinence. So that kind of gives you a trigger to think, well, if you did find something, they go back to 0 to 30 again, and I'm back to 7 rolling days instead of, a rolling 30 days, right? Oops, sorry, I didn't do that. So you've got, presumptive for the first 90 days for SUD is you get 3 presumptives in a rolling 7 days. And even in the old ones, they're telling you 3 in a week, right? And then after 90 days, it goes to 1 every 10 days or 3 in a rolling 30 days. And then definitive, you're doing 1 per week, right? Where you're doing 3 screens, you're doing 1 confirmation. Where you're doing 1 confirmation in a rolling 10 days, and then you're doing once basically every 30 days at 90 days plus. Now, your other group is your pain management, which is your COT, which is your chronic opioid therapy management. And again, same like what you saw for substance use disorder. Why are they ordering it? What are they looking for? These are the reasons. This is what you want incorporated into your requisition, that they're kind of check marking these things down, or that this is coming across in their patient history and their treatment plan and their prescribed meds. Now, there's one big thing about chronic opioid therapy is the frequency of testing, and they're really going to be watching this. And I mean, some of the LCDs are like, hey, I'm not going to pay for more than 12 of anything in a month unless I know that you're doing substance use disorder, and they're going to have specific diagnostic code requirements around that. Novitas is doing that. So if you're low risk, it's like twice a year at its max, right? And if you're at moderate risk, it's twice in a half year. And at high risk, it's at its highest is once a month, right? There are additional reasons for why they could do more testing, but you would need that recorded in the documentation, and they're probably going to deny you, and then you can send in medical records and maybe get paid. But you need to now do a risk assessment. Now, in many of the current LCDs, they say that you're supposed to do a risk assessment, but they don't give you an example of one. But in the new, what you're going to be moving to in the next couple of months, by the way, they don't have timelines on when they're saying that this is going to be implemented on any of them yet, other than the fact that Palmetto's just implemented theirs. You need to get these guys to understand that they should use some type of a risk assessment score. The one that they're going to bury in your LCD is going to be the SAMHSA one. And it takes 60 seconds to fill out. You count up the number of these elements, and then 0 to 3 is low risk, 8 or more, you're going to be high risk. And then that dictates the frequency of testing. You should get one of these every time they evaluate the patient, which should be at least once a year, according to SAMHSA, I believe. There are other opioid risk assessment tools. Medicare's like, I don't care, let them use whatever they got. If they don't have one, get them to use this one. You need to have this in your documentation for your client. And maybe this is a good time to look at doing a standing order with your client that's individualized for the patient, includes the risk assessment for your chronic opioid therapy patients. Maybe that makes sense for you to be doing right now. Yeah, it's extra work, but if you want to keep your money and they ask you for documentation and you don't have this, you're toast. All right, basics, non-covered services. We're going to have to sprint. Okay, blanket orders are not medically necessary. Don't reflex off a POC top. Medicare does not pay for both screens on a data service. Medicare doesn't pay for 2 confirmations on a data service, whether someone else bills it or you bill it, and you did a screen and they did a screen, they're just going to pay for the first one. And they say that in multiple different LCDs. Some of the LCDs don't say that, but they don't really need to say that. We should already understand that because the MUE says 1, right? So it's kind of like overkill to even say it, but they did. And of course, if it's not a diagnostic test, insurance doesn't pay for it. Just like they didn't pay for COVID when it was for return to work, return to school, travel, or entertainment. They don't pay for drug screens because you crashed your car or you were at work and did something wrong and they wanted to test you for that. That's not a covered health benefit. Reflex testing by reference laboratories are reasonable and necessary to verify presumptive positive UDT. So back to that other question somebody had asked about inconsistent, right? This is kind of where you're going with it. To confirm the absence of prescribed medications when a negative result, right? See, if I was negative on the screen, but I'm prescribing that med, we got to really make sure that they're really not on it before I accuse them of not taking the med. When medical record and documentation is individualized for a particular patient, satisfies medical necessary requirements found elsewhere in this LCD, direct to definitive UDT without presumptive UDT may be reasonable and necessary. So again, reconfirming, you don't need to do a screen every time either. You also don't need to do a confirmation every time either, as we've seen. So there's a lot of flexibility in that, and I think that's been confusing to people. Compliant confirmation maximization. Well, here's just my idea. Take it or leave it as you like. What's ordered must match what is billed. You can do this by a reflex. A reflex can be related to the medication list for the patient, identification of drugs within a drug class, medications that yield false negatives due to low cost reactivity, medications that cannot be detected by presumptive UDT. That takes work with understanding what your med list is, the amount, the meds that you confirm. You need to look at what you're screening and see the relationship of those meds so that you can build that into your reflex so that you can maximize in a compliant way, which will probably never get beyond GO481, 8, 9 things possibly, but you'd have to be on a lot of drugs, right, to even do that. Okay, comparative analysis real quick, just to kind of prove my point. I think I'm actually going to maybe, I'll be able to get through this. Okay, so Palmetto's old LCD was old as of yesterday, and now their new LCD is DL35724, same number. They didn't make a whole bunch of changes except that ethanol, and this is, you can see this in every future LCD, I'm saying the same thing. I'm seeing it again and again and again. Whatever LCD I'm looking at, they're all moving towards that. They just don't say it yet. So it's not happening yet. It will happen by date of service when they implement it. They just haven't implemented it yet. But they're all talking like, oh, ethanol's not really addressed. And originally in the first versions of the proposed, they were saying they weren't going to cover it. And they keep mentioning that it's not a DEA controlled thing, as if that really matters. Alcohol is a big thing. It's a big thing for substance use disorder. They're definitely saying, you know, that it looks like to me they're going to give us a hassle over alcohol. But I guess I would say is make sure people document why they need to do it. It probably makes more sense in substance use disorder than it does in pain management. I'd look at making sure I was addressing that with my clients in terms of what they want their reflex to be or their standing order to be. That, you know, if you're in pain management and you don't really think this person has a problem with, maybe you don't need to do that. If you do think somebody has it, then write it into that standing order why you think you're going to be testing them for that. So the frequency really didn't change. The way they set it, abstinence versus weeks or days instead of 7 rolling days and 30 rolling days and 90 rolling days, right? That kind of changed. The opioid risk tool in general is not there in the older version, but will be there in the new version. Although even in the old version, they told you you should do a risk assessment to satisfy the frequency of testing for your chronic opioid therapy, or well, no, not or, just with your chronic opioid therapy, you should be doing that. Then we look at the billing and coding articles. I wanted to point out a few select elements in there that I think are of note, right? Just to kind of show you there's some major variations right now, and they really are normalizing, and it really does look to me like it's going to match basically Palmetto eventually. So if you're looking for where to guide yourself, where you're headed, I'd look at Palmetto. So really all that happened for Palmetto on their billing and coding article is we gained a few more diagnostic codes, and those are what they were. And oh my gosh, I'm trying to remember what it was. They weren't super significant like another one that I want to talk to you about with Novitas, but it's worth checking out. Make sure you've looked at those and see how they might apply to your referring physician base. Now, WPS is still on their current one. I've got no expected implementation date for their future, but you're going to get more diagnostic codes. So yeah, I would take a look at that. They do want you, interestingly, differently than many other people, is they want you to have Z03.89 as a primary diagnosis and the specific diagnostic code as a secondary diagnostic code, which they don't specify what those are, but Novitas does. And if you look at Novitas, they're telling you they're F10.120 through F55.8. Those are all your specific drug of dependence, like cocaine or hallucinogen or whatever. So it's not every drug. They kind of sometimes specify them by drug class, right? And so that's what they're saying here. That doesn't look like that's changing for them in the future, but maybe it will. I don't see it mentioned in the future. Well, actually now the current Palmetto LCD, but that doesn't mean Palmetto might not add it. So if you were looking for things to do to bulletproof yourself for compliance for SUD, yeah, that's what you want to be doing. Is you want to have, well, for Novitas, it's going to be Z71.51 as the primary diagnostic code, and then the secondary diagnosis code being these F codes. They're using Z03.89, so you're going to have to watch those. But I would start really paying attention. And when you do get denials inevitably because you don't have the right diagnostic code, pay attention to what they're telling you about that. But you're going to have significant differences across the LCDs like that. Some of them still have specific PLA codes. It's interesting to me, a lot of the PLA codes are poof, disappearing. So all those people that worked for 2 years to get a PLA code and enjoy the satisfaction of using them for the past decade, they're probably not going to enjoy them anymore. They seem to be disappearing across the board. Trying to think of anything else. Yeah, and there's a lot of variation in the number of diagnostic codes that are happening across those. And then NGS, currently, they only pay for the G0480 and G0481, but their future proposed LCD, in alignment with everybody else, is going to bring back the 2 and the 3. But remember what I just got done talking about. That doesn't mean game on, go and build G0483s to those guys, because no, you won't have medical necessity for them. Definitely take a look at doing reflex. Really take a look at what you're screening and how that relates to the meds that you are confirming, so that you can incorporate that with the meds that are being ordered, so that you can deliver what the doctor needs by either ordering a reflex or doing some form of a standing order. And that's going to keep you in alignment with what's ordered, matching what you're resulting, matching what you're billing. Last thing, some commercial analysis, just a few little points, right? As you can see, there's wild variation. I just took a few of them. Cigna, 32 times a year. They don't mention COT or SUD, but you can guess that they're referencing, and they do in their policy, point out all of the policies for Medicare. Of course, they're pointing out in this policy, policies that are old that are going to be changing. But, you know, keep your head screwed on straight, kind of keep it all according to Palmetto, and you're going to have your best chance at arguing your way out of something that you really should be getting paid for. But that presumptive limit is obviously analogous to them talking about substance use disorder, not chronic opioid therapy management, right? So just kind of keep that kind of stuff in mind. Of course, they only pay for G0480 anyways. And yeah, you could get yourself into a potential false claim if your doctor is ordering a comprehensive panel and you're billing G0480 and they want to mess with you, they'll have right to do so, right? So again, reflex solves your problem. Nobody pays for validity. I was just kind of throwing that out there. And of course, Medicare doesn't either. Their rules are very similar with whatever rules they talk about, or the documents that they cite. And that's what kind of bugs me about all three of these guys' policy. There's a really small amount. I mean, you see how far and in detail Medicare goes into trying to tell you what to do, right? These guys don't really tell you much. And then they give you 10 pages of a bunch of crap to read through that are a bunch of different people talking about it from 2000, right? They don't mention that a screen is required. They don't mention that they don't pay for the individual analyte codes, but they don't. They don't say anything about the orders and results must match, but they'll bring it up if they got a problem with it. They don't actually have any diagnostic code limitations. United is also very terse on the subject of what they do and they don't pay for. And as you know, they probably have beat you to death with documentation requests when you build G0483. So reflex, and you got your problem solved. Aetna, they're only going to pay up to the G0482. Reflex solves that problem. And it's interesting, though, Aetna actually literally says this. I'll just show it to you, prove it to you, that, I mean, it's insane because they still pay for it. So these guys don't even follow their policy. But if they want to have a beef with you, they can. And so, where is it? Suspect, medically necessary. Not medically necessary. Simultaneous performance of presumptive and definitive tests for the same drugs and metabolites at the same time. And no, they're not talking about that you ran it on just an LC. They're talking about that you took one sample and you ran a screen and you ran a confirmation and you didn't ask somebody what you should run. That's what they mean there. And they're saying they don't want to pay for that, but they do. So, what you can see from a payer policy perspective and what actually happens don't match up a lot. My last parting words on that, and I know I'm 5 minutes over, is look, Medicare is pay and chase. That's what they call them. Well, that's what we call them. What they call themselves is a good faith payer. They don't have the information that they need to accurately tell if they've paid correctly on your claim. So just because they pay you doesn't mean it's right. Do not take that as some form of validation that you've figured out new coding rules or that you've worked out the system. No, Medicare has been very clear. They do not have the information required to properly adjudicate your claims. At your own peril, do you invite or, poke the bear? Eventually, they'll get around to you. They're about 4 years behind on getting to people from 2018 right now on some things. We're going to be spending the next 2 years going over what's happened for COVID. 2 years from now, they're going to be talking to you about what you did on infectious disease and what you're doing right now on your toxicology. All right. Were there any questions?
There are no questions right now, but does anyone have any questions to ask William prior to us jumping off the webinar? No questions, William. Well, with that, I'd like to thank everyone again for joining the webinar and William for presenting. We will be sending out an email which will have the presentation slides and a copy of the invite or the webinar. Actually, we do have one question, William.
Fantastic.
No, just a thank you. So with that said, thank you so much for all of you attending. Again, we will be sending out an email with everything attached to it. If you would like to have William have a Zoom with you and your team, please let us know. We can set that up. If for additional information, questions you may have, we can set that up for you. And with that, thank you so much, and everyone have a wonderful day.